Hey there, everybody. It's Jenny Clark with GovCon Summit, and today we're just delighted to have our Deepwater Point expert, Dr. Tony Hess, to talk to us about the impact of SARS, COVID-19 on the federal agency spending, our economy, everything else that you would want to know about it. It's unique to have an expert like this available that is completely up to date on everything that's going on. So I'm going to turn this over to Ariel Glassman, marketing at Deepwater Point, and let her make an introduction.
Thanks, Jenny, and thank you everyone for joining us today. Deepwater Point Principal, Dr. Tony Hess, will be presenting on the impact of COVID-19 on the federal healthcare agency priorities and directions. Dr. Hess has 31 years experience in the U.S. government sector. During that time, he has served as the Senior Vice President for CACI's International Healthcare and Life Sciences Business Unit, the Managing Partner and Senior Vice President for Unisys Federal Civilian and Healthcare Business Unit, the Senior Vice President for SAIC's Global Healthcare and Life Sciences Business Unit, the President and CEO of CTIS, and led IBM's Federal Healthcare and Social Services Business Unit, and is the founder of 2 companies. Dr. Hess received a PhD in physical chemistry from Arizona State University, after which he performed postdoctoral work in theoretical physics and theoretical chemistry, and joined the DOE National Laboratory System. He has published 47 peer-reviewed scientific publications, largely in the field of quantum chemistry and physics. He is currently engaged in designing next-generation systems for the Defense Health Agency. With that, I'll turn it over to you, Tony.
Thank you, Ariel, and good morning, everyone. From that bio, we can see that I have a short attention span. Let's see if we can share this here. Okay, so hopefully the screens look good. And thank everybody for taking the time to join us this morning in this conversation. The next few minutes, I want to talk a little bit about the impact that COVID-19 has had on the federal agencies themselves. We'll take a little bit of a snapshot look at the budgets. It's a very deep subject, and you can spend hours and hours and hours on it, which of course we're not going to do today. We're just going to take a kind of high-level view of the legislative component and then take a look at some of the findings from a special group called the PRAC, and I'll tell you who they are in a little bit. And then we want to move into 6 areas that we have observed that were either areas that got accelerated by COVID-19 or areas that have proven to be probably some things that we need to work on in order to prepare for the next pandemic that may unfortunately come to us. So without a doubt, and we've all lived through it, the pandemic was just a monumental expense. That was both in terms of the dollars and unfortunately the lost lives. It's a tragic event. The real engagement of the federal government happened at the start of the CARES Act. And one of the organizations that they created was called the Pandemic Response Accountability Committee. This is a great group. It's composed of 22 agency IGs and GAOs and a bunch of state auditors. And they're really charged with promoting transparency and providing independent oversight. There's lots of places you can find information about what's happening budgetarily on the internet, some US spending, for example, or COVID money tracker. However, this particular group is a group of auditors, so they're particularly oriented to keeping track of where all the money went and where it was spent inappropriately. So it's quite an interesting place to visit. The PRAC also publishes a whole series of reports. They talk about the challenges to the federal agencies, things that we should do that we have not done, and they often host panel discussions in topic areas like healthcare. And of course, as I said before, since they're a group of financial folks, they have a tendency to keep track of the dollars. And so this is just a snapshot of the legislative funding that has gone into COVID-19 across 6 different acts that have been signed into law to date. What I'm showing you here is this is directly from their website yesterday. This is a kind of simple way to visualize about $3.5 trillion worth of investment that the United States government has made to combat the pandemic. The bulk of the monies, if you kind of look around that circle, you'll see a couple trillions. There's a small business $1 trillion investment, and then there's a $1.2 trillion investment in individuals. And that accounts for about half of the total investment that has come through today. And those have to do with loans to small businesses, as we all know, and various kind of emergency support of that community. And then on the individual side, it includes unemployment costs as well as stimulus checks, right, to individuals. And you can see that there's other kind of special areas called out around there. Now today, I want to try to focus a little bit more on the healthcare piece. So we'll go into that in the following slides. But as you can see from this chart, the bulk of the monies that have been expended to date or been budgeted to date really have to do with offsetting just a tremendous cost that the pandemic drove, into the United States economy, both in terms of lost revenues or unemployment issues, just people not able to get the two ends to meet, as well as actually responding to the disease crisis itself, and that's the healthcare component. Down on the bottom, you can see that healthcare per se is about 7% of the total expenditure, and it includes all the normal things that you read about in the news. There's $150 billion that went directly to the providers. So the hospitals just got slammed, of course, when COVID happened, and they weren't prepared for it. It drove their costs through the roof, and they needed some relief for that. And the government kind of stepped up and provided those folks about $150 billion to try to keep everybody intact. So we had a functioning healthcare system. Also, we read in the news, a lot of money's been spent on vaccines, thankfully. Hopefully they help us out in the long run, as well as therapeutics. And then there's been a substantial amount of money that's been spent on mental health and some other components that are important for the population. Now, this chart doesn't show, as the little note says on the top, the most recent act that was signed into law, which is the American Rescue Plan by President Biden for another $1.9 trillion. It was just enacted last month, so the folks have just not had a time to sort of parse it all out into these kind of charts. But I wanted to give you a snapshot of some of the things that are in that bill that are relevant to healthcare. This is by no means the bulk of them, but it's some gives you an idea what's in there. This is about another 100 million or 100 billion or 110 billion dollars worth of funding just on this one slide. And I underlined some of the key words so you can get a sense for this here. There's a lot of investment that's being done in vaccines, their distribution, ensuring programs that ensure that people will have confidence in the vaccine and will therefore take it. And so there's educational components. There's investments in the supply chain. There's $6 billion in supply chain therapeutics. We'll talk a little bit more about supply chain in a minute. And then, but there's some specific investments in here that I think are good for the public health community, both today and potentially, in the long run. We look at the $48 billion investment in testing, contact tracing, and surveillance for a national-based evidence system. That's really at the heart of what the public health community has asked for many years and sort of desperately needs in order to keep track of the emergence of diseases in our community, and then promptly respond to them and get remediation strategies in place as quickly as possible. You also see some call outs on data modernization and forecasting. We'll talk a little bit about that. Public health workers, Defense Production Act, and of course, contributions to special communities like the Native American community and the veterans. So there is in short, a lot of money. When you look at these numbers, they look kind of small, maybe when you think about them on the point of the screen, $7.6 billion, so just 7.6. Well, when you think about it from the point of view, let's say you're a contractor, right? $100 million contract is a pretty sizable contract, and there's quite a few $100 million contracts, in these kind of numbers. So this opportunity space is vast for people that really want to, materially participate and help the government and therefore help ourselves to address these kind of problems. So relative to the agencies themselves, after they really got engaged, there were three small bills that were signed into law prior to CARES. The CARES Act, which was March of 2020, really accelerated the federal agencies' engagement in this activity. And as we know, our government is big; it's not super fast, so it takes it a little bit of time to spool up. But since March, the agencies have been very, very active. They have been overwhelmed, if you will, because they had all their normal responsibilities, plus the additional responsibility to process these billions and billions of dollars that have come into them. So the federal government's agencies are quite overworked at this point and finding themselves, like everyone, all of us, right? We're virtual, right? When normally we might be all together. They've got about 60% of their workforce is still outside the office. So they're challenged with the work environment. There's a bunch of security related issues that are complex for them in those kind of operational settings. And so, they're really kind of heavily overworked. at this point. And you also trying to manage your own staff, so that, making sure they're vaccinated and safe and secure. The fourth bullet is just a call out. If you're interested in kind of government-wide view, a quick place to get a snapshot of that is to visit this website, US.gov coronavirus response. There's about 100 agencies that the government aggregates there. Those are when you click on them, they'll take you to the specific landing page for that agency or that bureau or commission, and you can see what that particular organization is doing to support the coronavirus response and what it's doing with the funds that it's received. Overall, I think just to forecast a little bit, I think it will likely be in the fall, the first quarter of FY22. Government fiscal year starts in October, ends in September, of course, before we really see an opportunity for the new administration's priorities to roll out and for people to have time to absorb what those priorities are. And we're a democracy, so we'll debate them and to see exactly where the federal agencies are going to go. I think throughout the summer, we'll remain in a place where the workload is high. We're still worrying about controlling the immediate threat of this virus before we get on to planning where we're headed next. I can turn a little slide here. Go. There we go. So the PRAC identified some top challenges, and it's typical of this kind of group. They largely focus on administrative activities. As you can imagine, these are things that are identified by the PRAC. They published 2 reports here. The first 4 bullets are identified in the first report, and then the bottom 4 in the second report. As you can imagine, when there's this kind of this money coming through to these agencies, the financial management systems they have in place to handle both their own functions as well as when they pass through large sums of money, essentially flow it through the government agencies to states or to tribes or to other communities, state and local communities. All those systems were very stressed, and there's quite a lot of reporting about that. So the infrastructure that manages that kind of process inside the government, certainly needs improvement if we're going to handle these kind of volumes of money and the number of activities. There's thousands and thousands of contract activities, for example, that lie in here. So there's a lot of volume. The special circumstances produce a lot of IT security and management issues. You have dislocated workforces that are using the internet in ways that they weren't typically done. And then down towards the bottom, some of the reports on data transparency and completeness, this really cycles back to some key areas that are important to the public health community. You really can't have a public health surveillance system if you don't have data, right? So the data today, and we'll talk about this in a minute, is very siloed. It's not very connected. And as we all know, none of us could really get any solid information in the early phases of COVID about what was really going on. There was a lot of misinformation out there. And part of that just had to do that the government wasn't able to form a coherent view nationwide of this threat in the early phases. So what I'd like to do now is kind of switch over off the PRAC and talk about some observations that we here have made about COVID and its impact on the healthcare community. The first one I'd like to highlight is the use of virtual care. Now, virtual care is not a new idea. It's been around for a long time, and there's some leaders like the VA, Veterans Affairs, has been a leader in this area for many years. But during the early phases of COVID, and of course, we had a shelter-at-home order in place, and there was a lot of restrictions of movement in the early phases. And what this really did is it really dropped the number of routine and elective surgery visits to the hospitals. So people just weren't going to the doctor, couldn't get to the doctor. And this meant that healthcare was kind of halted in a way. Now, there's also, we're not going to talk about today, but if you think about it, the fee-for-service provider community and the commercial hospital systems, lost a tremendous amount of money as a result of that drop in workload, right? Now, at the same time, simultaneously with this, virtual care increased. So as the physical visits stopped, the virtual visits increased. So the VA reports that they had a 1,653% increase between February and November of 2020 in the use of telehealth video visits. And they're currently running around 41,000 visits per day. The CMS, Center for Medicare and Medicaid Services, reports something similar. Between March and October, they had 24.5 million out of 63 million beneficiaries using telemedicine services. Prior to that, they had 15,000 beneficiaries per week. So the volume of telehealth usage went up dramatically. And this is a technology that has been in the wings for a long time, and COVID really accelerated. And it's a technology I think is here to stay. And for those of you interested in this area, there's a lot more to do. Just to give you a couple highlights on this, the American Hospital Association testified to Senate subcommittee on March 2nd, and they talked a lot about the benefits. Okay, there's kind of obvious ones, right? So you have better access to specialists. Some of the ones that might be so obvious is that you can manage people's care and get them to the right emergency department or hospital based on the kind of things that's going on with them without having to, maybe you don't even do it, right? Because you can just imagine at home. Or if you have to take these people in, you can get them to the right place much quicker. It also has an interesting dimension. There's a lot of social disparities in healthcare. It's not a topic, we're going to explore today per se, but you can see quite easily that if people are in a rural community and they don't have good physical access to healthcare, a lot of times these people are not, affluent, right? Some of them may not have a car, right? This is a way that healthcare can actually reach out to them. And there's a lot of work in allied communities. There's a couple of active solicitations in the OTA community for increasing broadband access to the rural health community. And we'll see that continue, I think, as it goes forward. So things to kind of watch for in fiscal year 21. I think we'll see legislative changes to support the use of this care delivery model. There are many waivers. If you want to dig into this, you can go to the Center for Medicare and Medicaid Services website, and you can take a look at the waivers that were necessary to get the doctors reimbursed when they saw patients in this televideo, teleconferencing kind of manner. I think you'll also start to see this get involved in incorporated in value-based care reimbursements models. So these are new payment models that the community is exploring. As I said before, broadband initiatives. And then there's a lot of parts of this that have not been really used effectively yet. So today, we're largely talking about synchronous communication between the doctor and the patient, but there's much more that this kind of technology can do. You can do remote patient monitoring, so you can collect information to review and make decisions on, possibly with instruments. Medical adherence, e-triage, I talked a little bit about before, is getting the right people kind of triaged so that they enter the hospital system in the right sort of way. Key agencies, the VA has been a leader in this area for a very long time. They have a dedicated office to address virtual health and virtual remote care. And of course, we have Health and Human Services of all the several different components, which I've listed a bunch of acronyms here, but these are parts of the big HHS organization that are responsible for special communities. And each one of them has a certain take on what this particular technology can do for their constituents. So another area is public health systems and reporting. This is an area where we need to improve. Data collection is at the heart of a public health system. Unfortunately, today, there's still a lot of people in the country that use pieces of paper and fax machines to get the information transmitted from the field, like a hospital, right, to a place like the Center for Disease Control in Atlanta, where the experts need to get that information in order to make decisions. We should probably have a little bullet here that says death to fax machine. It's about time to get off the fax machine. So this is unfortunately the state of affairs, and investment needs to be made here. The data is also in the United States, when it is collected electronically, it's very often siloed. And that means that an organization will collect it in their own information system, but they don't necessarily have a provision to connect to other information systems and roll it up into a unified view. So we have a highly fractured system. Now there is over the last, since around 2006, there's been an initiative in the United States to put national health information exchanges in place, and they're largely operable at this point between hospitals that comprise the provider community. However, the public health system is really not properly connected, into those networks today, and so there's still a kind of a chasm between the public health community and the healthcare provider community in this regard. So what do we need to do? We need a whole national data architecture with established rules that breaks down these silos and collects the information that's necessary for the public health professionals to be able to quickly realize that something new has been introduced to our population and do something about it. So what to watch for? I think we'll see there's a lot of funding that came through in the CARES Act, and I just talked to you a little bit about stuff that's in the American Rescue Act that will buttress and help move the public health community forward. But I think what we're really talking about here is a sort of public health reporting system 2.0. And you can see some ideas in the current administration starting to spool up and talk about that more. And I'm sure we'll see much of that to come in the coming months. HHS is likely to be a leader, certainly HHS's CDC component, but there are other components like ASPR, which is a part of HHS. That stands for Assistant Secretary for Preparedness and Response, that will be, play figuratively in this. And then of course you have the agencies like the Homeland Security, the Defense Health Agency, the Indian Health Service, and the VA. All of those folks have hospital systems, particularly IHS and VHA and DHA, right? Those are where those organizations are responsible for actual hospitals in their networks. And they are both a provider as well as a community that monitors and needs to address public health threats. Another area that we struggled a little bit with was emergency medicine. So we're not talking about small things here. What I have in mind now is in the early phases when you saw people in gymnasiums, right, being pulled together, dislocated persons based on mass casualty or mass events. When this happens, what frequently occurs is that organizations like the National Guard, and in some cases, we saw with the Comfort and the Mercy hospital ships, we may even see active military uniformed personnel attempting to help, right? When that happens, those are called DSCA activities, the Defense Support of Civilian Authorities. That's a type of authorization of the government. When that happens, extra difficulties occur. Basically, the military systems are highly secure systems that have been developed for special purposes, namely supporting our troops, in national defense. And those systems use technologies and standards which are different than the civilian community uses. And so there's a kind of fundamental disconnect and a difficulty to transfer information between the electronic health record systems across those communities. We also continue to have a situation where the hierarchy of care here, where you have first responders and then maybe have a small field hospital or tent system up to gymnasiums, all the way to brick and mortar. That hierarchy of care, what the military calls role 1 through role 3 kind of care, is largely in an information context fairly disconnected. So it's not unusual in the United States, in fact, it's quite common in the United States, to find ambulance services, for example, that have light versions of electronic health records being used when they have their first encounter with the patient, but then as they get to the hospital, they often fill out a piece of paper and hand it to the emergency department, right? So this whole system needs to be integrated vertically so that information can flow, from the first responder all the way through to wherever you're going to encounter qualified medical personnel to assist the person. So I think, things to watch for in 22. I think we'll see improved defense support civilian authority capabilities. I think we'll see focus on DSCA, be more conversation around how does the military health system, when needed, support the civilian health system in times of disaster and threat like we just went through or hopefully don't go through again soon. And then what do we do about the data architectures necessary to ensure that this data flow happens, across this emergency response community? Key agencies here will be the ones on the bottom. You'll see a little bit different mix of folks here. You'll see FEMA get involved in these kind of conversations, as well as CDC, HHS, and DHS, and VHA. So supply chain manufacturing and logistics. This is one we all live through, right? Shortages everywhere, right? Well, that was a problem. So part of this was because we don't have a sufficient manufacturing base in the United States for some of these items. I don't know what the exact number is, but I've seen numbers as high as 95% of the masks were actually made in China, not made in the United States. And something very similar happens for PPE. So there is a move afoot to try to figure out what to do about this inside the government. And this goes everything from simple devices like masks up to the raw materials necessary to manufacture vaccines and drugs and therapeutics, all the way to finished pharmaceuticals. There's also, we know from, if you watch the news, a lack of coordination between the federal and state governments for accessing medical equipment, countermeasures, and supplies. And we went so far as we actually saw people competing across different components of our government to access supplies that were needed, masks, for example, bidding against one another. So there needs to be greater coordination there. And I think it's widely recognized that we can do better on that front. And then finally, inventory management of stockpiles. So all the agencies do, well, not all, but many of the agencies do stockpile medical supplies and countermeasures. There is a national stockpile, strategic national stockpile, which specifically is, geared to do that. But what we don't have is a good visibility into what all those stockpiles are holding, and we don't have the data analytics to forecast the demand and the demand location at this point. So there's again a need to get better information, about these systems, and to have those systems reporting to the right people. So we'll see, I think, in things to watch in 22, efforts to streamline and increase the visibility into the national supply chains. Who has what and where is it needed? Kinds of questions. I think we'll see a revisiting of our national stockpile. There's been a lot of discussion in the last year about national security, strategic national stockpile 2.0. And then the meshing of that concept with the agency supply depots, and then the functions that special organizations like the Defense Logistics Agency perform to make sure that those supply chains are functioning properly and that things can be procured and delivered. And finally, I think we may also see some new policies that get introduced, possibly incentives in the form of tax breaks to incentivize the manufacture of key items here on U.S. soils. So key agencies, again, kind of normal cast of characters with some additionals people like the Department of Defense's material commands. These are parts of the Department of Defense that stockpile medical supplies so that they are prepared to deliver them to the troops as needed. And then organizations like the Defense Logistics Agency. So preparedness and response, this is a broad topic. It has been around for a long time. It really, after the anthrax attacks in 2001 and through the Bush era, we saw the first creations of these national defense strategies specifically. The current administration has put out a new plan published in January 2021, which builds upon some instructions that were provided in the 2017 National Defense Appropriation Act. So the plan that the current administration has put in place, you can go and find it. It's quite interesting. It's about a 130-page document. It has 7 different focus areas of areas that need to be addressed to ensure that when these kind of threats happen, we're prepared. Number 7 is specifically around healthcare security and building better preparedness for future threats. As a very interesting part of the document, it's heavily focused on the public health community. It talks about strengthening the public health infrastructure, improving the data and IT systems, a lot of things we've talked about here, right? It specifically addresses them. Talks about a plan to revitalize the national stockpile, and then all of the things around securing the pandemic supply chain. And it even mentions the creation of a new entity, which doesn't exist today, called the National Center for Epidemic Forecasting and Outbreak Analytics. So overall, I have to say I was a bit encouraged by reading that plan. I think it goes a long ways to talking about the needs of the public health community to guard against these kinds of disasters in the future. In this case, that's actually a responsibility of the assistant to the president for national security. So the National Security Advisor has been specifically tasked, and you can go to those websites if you want to find out kind of what the administration's thinking. And finally, contact tracing, surveillance, and testing. So this is an area that was particularly highlighted by COVID. COVID had this nasty habit of having asymptomatic spreading of the disease. And even when you didn't have asymptomatic spreaders per se, there was a long incubation period during which, before you got symptoms, you could actually give the disease to someone else. So this is a kind of traditional epidemiological difficulty. Normally the way the community would handle the spread of disease and contain it is through a method called contact tracing, where they try to, once you know you're infected or you have symptoms, the community will attempt to identify all the people that you came in contact with them and interview them, and then try to quarantine them to stop the spread of disease. That's tough to do in COVID. So the emphasis really shifted, since you can't really see that someone is sick, the emphasis really shifted to testing. And so there's a lot of information and news about test kits and test processes, test laboratories we've heard about over the last 6 to 8 months. And the reason for that is you really have to have those tests with this particular disease to even know if someone has got it, right? So we found that there was a lot of issues, and we'll see a lot of strategies to stop this kind of problem happening again in the future. So meaning we need to have more rapid tests, more broadly distributed in a timely manner to combat a disease like this. We're also in a place where all of us can go out today and we can buy a Garmin watch or an Oura ring, and we can collect a lot of bioinformatics or biometrics about ourselves, using those devices. And those little devices even have algorithms, AIM kind of algorithms that will based on our physiological data that they're collecting, will forecast whether or not we're sick, right? So this is done at an individual level. It has not yet been done in a large group level. There are a lot of privacy concerns with doing something like that, but we'll see, I think, additional conversations around the use of technology, specifically proximity tracking devices. So this is a technology where you have the ability to determine when someone has come within a too close for too long kind of setting. So they're often little fobs, or they could even be little devices like Bluetooth sensors on watches. But what they help you do is that when the contact tracers go to work to try to figure out who you've come in contact with, it provides a good starting point for those folks, because all of our memories get kind of hazy after 3 or 4 days when someone's asking you, who did you see, right? So these kind of technologies can help those contact tracers get a better starting point for the manual process that they have to go through to really figure out who's sick. So I think we'll see that. We'll also see new architectures to support that kind of data collection, assuming we can get over the privacy hurdles associated with their use. And then there's certainly an opportunity, and there's good examples, as I said a minute ago, of using advanced machine learning and artificial intelligence tools that can be fed physiological data and look quite promising for forecasting the onset of disease. So this is another tool that might emerge in the kit of the public health professional in the future. We also need to, and there's some investments that were made up on the top. I showed you some of them in genomic testing for disease strains and variants. So you have to rapidly determine what pathogen you're dealing with and whether or not there's a variant of that pathogen that's emerging in the public health community. That's a complicated process. It's, we've all gotten kind of used to the idea of genomic testing, but in reality, it requires very special pieces of equipment and very highly trained people in order to do those analyses and draw the correct conclusions. So I think we'll see additional testing on that front. And then finally, as I said before, we need to focus on the national testing infrastructure and in making improvements in that, and then making the connections between the public health community and those hospital endpoints. Here you'll see leadership coming here, I think, mostly out of the military health system, as well as the CDC. So for those of you who are familiar with the Defense Health System, they have a very special community, and they have an ability to introduce and test some of these new technologies a little more easily than you can in the broader population. So finally, just kind of closing remarks. Every administration over the last 30 years or so has had some thinking around a biodefense response. The reality is that preparing for the next pandemic, ties up a bunch of needed capital, and there's always a trade-off between the needs of what you have to do and address today's issues, and planning against an uncertain future. This is proven to be difficult for the government to balance those priorities. Over the last couple decades, COVID may have provided the energy to increase the focus on preparedness. Going forward, I hope it does. And I think a bright spot here, honestly, is the biodefense strategy that's been put out by the agency, by the president's office. Hopefully, we can build upon that and take that as a set of guide rails to move forward and buttress our public health community. Now, I think, as I said at the kind of beginning of the talk, I think clarity and directions and priorities of the agency will probably wait until late summer. The agencies are, they're heavily involved in processing the funds that need to be passed through to the extra community, as well as pursuing their multi-year goals that are already in their planning session. And again, with another stimulus bill coming through now from the American Rescue Plan, additional work will happen there. And then just finally, just a recommendation. I think if you're interested in these programs, it's essential to speak with the agency directly, right? The plans, it's a fluid situation. The plans change regularly, and the people that really know the direction they want to take are actually found in the agency. So I would encourage you to, if you have something to contribute, I would encourage you to go speak with them directly. And that's it. Open for questions.
So Ron, what you've given to us is so impactful, because every area of our lives is affected by components of this. And what I'm thinking about is when they let the contract to upgrade the military's healthcare system, that's tied into this. The other thing is the cybersecurity of people's medical information and the value of a social security number and a Medicare number when you talk about cybersecurity and fraud in the medical system. There's so many pieces to this, and I guess I'm kind of wondering, how do you see this being in a way coordinated by any particular contract? The other thing we're always wondering about is, where is the money going to be funded for small business? It's not like there's going to be a brand new prime contract they can bid on to get in it. They've got to find their teaming mates and partners, right? So
Right.
where does somebody start with all of this?
Well, all of the agencies are, somewhere between 30 and 40% of the total dollars that the agency has available typically go out to small businesses. So there really is a tremendous volume of resources that are available, for the community. Now, kind of two parts of how you could do this. One is that you can watch the normal solicitations, right? But before the solicitation happens, you really want to be way in front of that, and you want to be talking to the agency to really understand what their priorities are. Now, if you're a small business, it can be difficult to get into those agencies. So that's where sometimes partnering with larger companies that the agency has got big contracts with, that regularly turns to for advice and counsel, right, can be very beneficial to a small company. So forming good relationships that are meaningful, where you can make a contribution to the prime contractor or the larger companies' activities, are pretty critical to being successful, I think, and getting to the right people. You also have to have past performance, right? And so that's another good way for a small business to gain past performance. You get a few people, maybe 10 people on a contract with a large prime contractor that maybe has a 200 person activity going on. And that, of course, gets you experience and shows the government that you're capable of reliable delivery and can meet the objectives. In terms of your question about, will there be a single contract that binds them all? I do not think so. I think we'll see, centers that will, I think you'll see activities in the military community. You'll see activities that are sponsored by various federal agencies. We may see new organizations stood up, like the Center for Epidemic Response that we looked at earlier. And those will be focal points. And those focal points they will address components of the community that they're responsible for. But I don't think we're going to see a kind of one ring that binds them all.
Yeah, I think that's what the problem with all of this is people say, well, the government is a relationship with a specific person on a specific activity of knowing where to go. And I think the main comment we've heard during our discussions from the veterans community is like, if they say I'm getting a shot, I'm getting a shot. So it does seem like going after military health would be the first place the money's can be spent and where more of the direction can be made. And that's just kind of a guess. The other thing that I think is a unique opportunity for this particular community that we've got inside federal contracting, and the people that I targeted, is a lot of the federal contractors are used to operating overseas, OCONUS. They've already got activity, they've got deployed personnel, they know how to operate overseas, and that's a unique area. And that's one of the reasons why we put this whole event together around, I started just calling it in general, the COVID Coalition, with the idea that there are companies involved in this little ecosystem that are doing cybersecurity, that are doing healthcare IT, that are doing operating overseas in various communities, and to try to identify people with background in the medical community, for example, the medics and things like that have now stood up their own companies. The other one that we've got that's been quite interesting, and this kind of goes back to every really bad event that's ever come up that's handled by FEMA, whether it's a hurricane or tornado response or something like that. And that's trying to get people out of tents into kind of mobile units. And that was one of the reasons that I texted Ron Ben-Zeev to pop in on this particular session. And hey, Ron, I'm going to put you on the spot. Is that okay?
I'm used to it.
All right. Well, I'm going to put you in the center if you put on your thing. And I just want you to know that this guy is one of the most dedicated people, Ron Ben-Zeev, trying to solve really the humanitarian side of this, because he's got World Housing Solutions. He says, Jenny, I've got these shelters. We can throw people in it. We can deliver vaccination. The rural people are not being solved, but it's almost by the time he'll find a pathway to the money to produce these, it'll be over. So Ron, do you mind giving Tony just kind of a background about World Housing Solution?
Absolutely, thank you for indulging me. Tony, we were born about 10 years ago, a bit over 10 years ago, to help respond to the challenges of humanitarian refugees after the earthquake in Haiti, and developed a shelter that could be assembled by hand above ground to eliminate the need for drainage. It was rigid, insulated, doesn't mold, mildew, rot, and unfortunately, nobody cared. The answer we got time and again was, hey, this is very interesting, but a tent is good enough. We were then discovered by the Seabees, who said, hey, interesting little shelter, but can you make it bigger? I'm an entrepreneur. The answer is almost invariably yes. Tell me what you need and let's see if we can figure it out. And so we made a larger shelter. They liked it. They wrote an after action report and evangelized it. And I'd love to tell you that since then we're drinking champagne, eating caviar, and flying in our Gulfstream, which is not true. So it's a roller coaster effect. It's we get the contract, we fulfill the contract, we deliver the contract, and then we wait because what we do is educate. So military is used to tents, military is used to containers, and we step in the middle and we go, we're none of those. But think of us as IKEA meets construction, but so efficient that once you're in, it's like being inside of a Yeti cooler. And even though it is a rigid shelter, it sidesteps all the MILCON requirements because we're considered expeditionary. Everything we make can be done and assembled by hand. Smaller shelter we've done is about 300 square feet. The largest one is almost 4,000 square feet. And we've done everything from onesie twosies to a full LSA and anything in between. And then what Jenny was alluding to was the fact that we also delivered clinics on wheels, utilizing the technology and the efficiency that we've learned. One of the biggest challenge I had at the beginning is I always talked about how green and holistic and kumbaya we were, and all I got was, military on the other side looking at me and staring at me like, what kind of a crazy hippie is that dude? Ultimately they said, we don't care if you're green. Here's the problem we're trying to solve. If you can solve the problem and you are green, sweet, we'll buy your stuff. We're not gonna buy you because you're green. So we changed our story, not what do we do, but our story changed from holistic approach to blah, 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 to, hey, we reduce your logistical burden. Right?
That's very interesting. So on that last point you made, this is something that I see a lot, is that companies will approach the government with a statement of kind of who they are. And it's, the government will very rarely, in my experience, translate a message like that into what they are, right? So pretty much essential, right? That you wrap yourself with a flag, right, so to speak, Ron, in a circumstance, what you just talked about, right? I mean,
yep.
You have to do the work basically to translate to their mission, and you have to understand their mission enough to really get that on target.
And we missed it, and I'll take the blame for a few years. We were walking around going, "Hey, green, holistic, kumbaya, let's hug it out," until someone said, "Logistics kills people. 58% of all casualties in Iraq and Afghanistan came from the logistical side. Solve that, you got our attention." But I am. We go, great. How? Well, we're 300% more efficient than a tent. We're 150% more efficient than a container. So suddenly your fuel use, and so that has been our challenge. And as Jenny alluded to, we start conversations, we bring it all the way to the 1 yard line, and then the person leaves, right? And then suddenly you go, oh God, what happened now? And now I need to start from zero. Because what we do is unusual. We have to educate people as to, hey, I know you know tents, I know you know containers. Oh, by the way, do you know there's a third thing that gives you all the benefits, more benefits than a traditional structure or building, but with the ability that you can pack it up when you're done and move it. And that has been our challenge is consistency, filling the pipeline. And I chuckled, by the way, and it was more of a grimace when you talked about small business, because look, we've lost, or we tilt against, small companies, small businesses that are billion-dollar entities that are just under the 500 people threshold. And we're looking like, how is any company that sells anything that starts with a B is considered a small business? It's insane. It's unfair. Such is life. But we sit here and we go, that makes no sense. We're small business. They're not. But that's for a bourbon conversation, I think.
Yeah.
Well, and the reason I wanted Ron to come on is because if there's a person that's done everything possible to be successful with a product that really makes a difference, it's Ron. Because I first met him when I heard he said, how do I get on a GSA schedule? So I sat in his office and learned a little bit more about him. And I said, how many of you sold? What do you need to do? And it turns out he couldn't get on a GSA schedule because he hadn't sold directly as a prime. He's always been under a very large company's GSA schedule. And so, when it comes up, they'll sell stuff. So we can't get to that. The next thing they said, well, can you put it on a credit card? He got set up for a credit card. Then they said, well, what if you went after SIBRs and OTAs? So he's got an AppWorks SIBR award. And this is really the same story I hear over and over. And part of the reason why I wanted him to describe it, because it's like, I do think that there's a lot of opportunity out there if we could just figure out a way as a team to crack that code. So any other thoughts on that, Tony? I mean, these are the things that people struggle with, and part of the reason why I think Deepwater Point exists.
Yeah, there's a number of things we could talk about. Several that occurred to me at the moment is, to guard against this instability of revenue streams. Right. One can, and it sounds like, Ron, you've tried this, but it might be worth continuing to pursue it. To become a supplier essentially for that component that you're, geared up to provide, as part of a much larger contract, right? Because those larger contracts will typically persist for quite a while. Now, once you get in the door, what you might want to consider doing is trying to, expand or reform the structure of what you're offering, such that you have more stickiness with the kind of long-term, life cycle of that contract. So for example, maybe you enter by just providing the product, but a couple of years later, you're also providing all the siting of the product, the support of the product, providing labor and other category areas that the prime contractor knows that you can deliver, or you specialize in a certain region of the world, where you're comfortable and they have difficulties. But this whole idea of you want to be as sticky as possible, in those kind of larger contracts. Another thing that I've seen smaller businesses do in these, and I've done myself in these kind of circumstances, is to refactor the offering such that I can bridge that gap. So I don't know enough about your business, Ron. I'd be happy to talk about it, but brainstorm some ideas about what else the product can do, right? Other than what you primarily are interested in having it do today, right? Such that you can access other communities or adjacent business areas. But it's difficult. You have to survive a long time, right, in this community to be successful.
Well, here's another one, and you've already met Ashley Gillis, but I think me and Ron and Ashley are going to be talking about this because we feel like there's opportunities over in Africa for creating a combination of the services and the other. And Ashley, yours is curriculum development and training, is that right?
Yeah, that's part of it. I'm dying to ask the question, Tony. So you were talking about this public health reporting system. And one of the things that I think has been clear about with this pandemic is the international community getting their numbers in, and then, us getting the Americans getting our numbers in. And that was part of a big failure on it. I mean, the World Health Organization has their standards for for reporting, within 24 hours and all of that. But how are we going to work with our system, making sure that the international community can gel with us to really make this work?
It's funny, I can't remember who said this last week. I just read it. Might have been the CDC director, but the person's remark, the official's remark was it's sometimes easier to get accurate public health data from a small system in Africa than it is to get it from the United States. And there's probably some truth to that, right? Because the system is new, maybe newer, right? It's self-contained, it's in a certain geographic area, right? It's operated by staff that are, put in place to do that function. And in the US, we never designed the US healthcare system against a template, right? So there's there's 5,000 plus individual, actually the CDC, I think, is receiving public health reports from, I think, around 7,100 reporting entities today. And, I doubt if there's a lot of consistency on how those reports are presented to the CDC and, across the country.
Right.
Well,
So I think we might be kind of the issue in a way.
Yeah, I can imagine. So thank you so much, Tony, for being a part of this today. We had a lot of great information that you shared. And the reason for doing it is to let the small businesses in this community know how many different directions they could go as far as pursuing work in this area. We've actually got Stephanie Johnson on, but I don't have quite enough time. She got her 8A recently, and I said, Stephanie, you've got a background in accounting and auditing. Let's find a way to go after the audit side of this. And she's already got several contracts in that direction. So our idea is to combine resources among some of these companies, mentor each other, figure out where it is, and try to work forward. But I did want to mention that Deepwater Point has been a fabulous partner with us for GovCon Summit and providing a lot of capabilities and services. And basically, you guys know where the money is and where the market is headed, and that's why you're such a valuable resource. So thanks so much for being part of us today, Tony. And any last minute thing you want to add to it?
It's been enjoyable. I hope that we can continue to talk, and I'd be delighted to talk with any of you about, challenges or opportunities that you're interested in.
All right. Well, thank you so much.